A very good evening to all the participants. So today, the webinar is on precision medicine in COPD management. So for this today's webinar, we have participating moderator with us, a well-known figure. The webinar is on Dr. Shamal precision medicine in COPD consultant physicians. So for this today's webinar, and we have apnea center moderator along with well-known figure. Sir, we have Dr. as a guest speaker, Dr. Apar Jindal sir. Sir is a clinical director at Lung Transplant and Pulmonology Critical Care and Sleep Medicine, MGM Healthcare, Chennai. His presentation is done by Dr. Prashant Kumar, Senior Consultant and Director, Respiratory Critical Care, Sleep Medicine, IQCT Medical College and Hospital, Durgapur, West Bengal, and two esteemed panelists, Dr. Anil Agrawal sir and Dr. Abhishek Kumar sir. So with these brief introductions, so it's my privilege to hand over the sessions to Dr. Shamal Sarkar sir. So before hand over the sessions for all of us, just a two line that we all know that is a expert opinion is a fundamental base for any consensus or any guideline. As the process journey start with the clinical experience, expert opinion proceeds into clinical trial, systemic analysis, meta-analysis, and finally the guideline that we follow. And thus there is an importance of each webinar and hence the today's. So with this, Dr. Shamal Sarkar sir, it's my privilege to hand over the session to you for further moderation. Sir, please.
Thank you, Dr. Sachin. Good evening, everybody, and welcome to the webinar today. At the very beginning, I will give an introduction to the subject, precision medicine in COPD. The burden of COPD in India is very high and progressively increasing. India has 18% of the world's population, but 32% of its COPD burden, with a prevalence 3.3% to 4.2%. As estimated, COPD is the fifth leading cause of death and second leading cause of death in India. And 5 lakhs of people die due to COPD in India every year, which means 4 times greater than the people who die due to COPD in USA and Europe. 10 lakhs deaths were in 2018 as estimated by Global Burden of Diseases. There are certain other important points related to COPD in our country that I must highlight here. Of course, India has a very high burden of COPD with regards to prevalence, deaths, and deaths. With regards to risk factor related to COPD, as we know, tobacco smoking is the most important risk factor globally, particularly in the well-developed countries. But non-smoking risk factor accounts for about 70% of COPD in our country. That means most of the COPDs we come across in our clinical practice may be non-smoking risk factor phenotypes. Now, community epidemiological studies was done that showed a significant number of COPD cases remain undiagnosed, and COPD is very poorly recognized in the community. Most of the people in the community, they never hear about the word COPD. Another important fact is that most patient in COPD in our country is detected in the later stage. That means in the advanced stage, and many times usually during an acute exacerbation. But the last point written here is very important, that COPD remains poorly and incorrectly treated by the physicians. As you know, COPD is a complex and heterogeneous disease, and this dynamic complexity and heterogeneity explains and justifies the need for a precision medicine approach. Precision medicine involves the use of clinical and biological information to predict the therapeutic response. The final objective of precision medicine is to improve the clinical outcome of the individual patients while minimizing unnecessary side effects for those who are less likely to respond to a given treatment. Now, how the COPD guidelines are evolving. over time, COPD guidelines are evolving to reflect a more individualized approach to treatment. If we see way back in 2006, the GOLD 2006 recommended FEV1-centric approach to COPD management. The guideline recommended at that time to do FEV1 for the assessment of the severity. Treatment was given according to the FEV1, but there was no consideration about the degree of severity of the symptoms, frequency of the exacerbations, associated comorbidities, etc. It was directed by the guideline that patient has to be classified as grade 1, 2, 3, 4, or mild, moderate, severe, very severe COPD. And according to the stage of the COPD, treatment was given. So it was a sort of one-size-fits-all treatment. Then for the first time towards a more individualized approach to treating patients with COPD was the revision of the GOLD guideline in 2011. 2011 GOLD guideline recommends COPD patient has to be stratified by airflow limitation, exacerbation history, and symptoms, and group them as A, B, C, D grouping and give them treatments. So it was to some extent improved form of treatment, just stratifies medicine. Thereafter, more recent guidelines and evidences showed that FEV1 has very poor correlation with the severity of the symptom, with the prognosis of the patient, with the frequency of exacerbation, and most importantly, FEV1 has very poor correlation with the response to pharmacotherapy. That's why in the recent guidelines, FEV1 was separated from the ABCD grouping system. Now, what would be the goal in the future? In the future, it may be possible to identify particular phenotypes or groups of the patient that best benefit from the specific treatment. So, as all COPD patients are in not the future, it may be possible same type of treatment cannot be given to all COPD patients. Recently, there is a paradigm shift in the COPD management. The new GOLD guideline has moved in a direction to give the concept of personalized therapy. GOLD has issued some general criteria of escalating and de-escalating treatment based on persistent symptoms and further exacerbation. As you know, ICS, LABA, and LAMA, these are the three classes of inhaled medicines that are used either alone or in combination for the treatment of COPDs. So this is GOLD 2020. As you can see, there are two blocks here. On the left side, for the initiation of pharmacological treatment, and on the right side box are guide for the follow-up pharmacological treatment. I think this is a very precise, very important, and very easy algorithm system provided by the GOLD 2020 to all the physicians to adjust their treatment and treat their COPD treatment effectively. Just two questions has to be asked as the severity of the symptoms, to assess the severity of the symptoms and the frequency of exacerbation during the 12 months. These are the two important clinical points highlighted in the new guidelines, and it has made the physicians' assessment of COPD and to start treatment and to work up thereafter in the follow-up treatment very easy. And in my suggestion, it will be better to keep this chart in all physicians' clinic, so that whenever a COPD patients come in front of this in the clinic, so every physician should use this chart for initiation of the treatment and the follow-up treatment, and then only the COPD treatment will become very easy and more perfect. But what the real-world data shows, the real-world data reveal that the most of the patients with COPD are not treated according to the recommendation. So this is a spirometric study amongst the symptomatic COPD patient. The study report shows that inhaler management in about 50% of the patients with COPD is not aligned with GOLD recommendation, with half of this being undertreated. Most importantly, the patients are either overused or underuse of the drugs. And in fact, GOLD A category, that is mild degree of the patients, are always overused by the treatment. There is another important point about inhaled corticosteroid use in COPD. There is a dilemma. There is an imbalance between the risk and benefit of use of ICS in COPD patients, but GOLD recommends ICS use only in a small and selected group of COPD patients. But there is a discrepancy between guideline and the real-life prescription pattern. with up to 70% of the newly diagnosed COPD patients are receiving ICS-based treatment from the very beginning, irrespective of severity and the stage of the disease. So clearly there is an overuse of ICS in COPD, predisposing the serious side effects, including pneumonia. The overuse of ICS appears to be a product of history. I think there are certain factors which results in the overuse of ICS. For example, previously, ICS was prescribed by the physicians to the patient with COPD by merely analogy with asthma treatment. In addition, primary care physicians often lack spirometry at the baseline to help differentiate between asthma and COPD. And this might favor a treatment choice that covers both the diagnosis. Moreover, the initial ISOLD and later TORCH studies, which confirm superiority of ICS alone or in combination with LABA over placebo in terms of exacerbation prevention. And the result of these initial studies has most likely provoked physicians to advise ICS-LABA combination in COPD treatment. However, more recent studies have challenged the supremacy of ICS. And another important point, we must remember that LABA-LAMA combination was not available previously. This LABA-LAMA combinations has only recently become freely available to the physicians for the treatment of COPD. So these are the most likely factors which are responsible for the overuse of the COPD treatment by the physicians. Now, again, the box is coming here. We can see the GOLD guideline recommends to divide the patient into A, B, C, D grouping. And if we see the treatment given to all the groups of the patient, you will see in every case, there is either LAMA or LAMA, LABA or LAMA-LABA. So everywhere, there is LAMA or LAMA-LABA combination. That is long-acting bronchodilators, either alone or in combination, is the drug which was given in all groups of the patient. This just indirectly, it is also saying that physician who may be not so much experienced in treating COPD patient, but after diagnosing COPD, if a physician advises either LAMA or LABA-LAMA combination to any COPD patient, he will not do any blunder. Definitely the patient will be benefited. But if we search about the ICS, position of the ICS, you can see it is here. It is here only in the group D. That's also in the third line. What does it mean? It means that the ICS use in the COPD is advised only a selected small group of the patient. And these are usually high-risk patients with frequent exacerbations. So this is the recommendation. LABA-LAMA can be used in any group of the patient, but ICS in a very small selected group of the patient. But what happens again in the real world? So there is a production here. Again, the patients are triple therapy. That is the combination of ICS, LABA-LAMA. This is the maximal pharmacological treatment we can give to our COPD patients. So where is the place for this triple therapy? The real data shows that the use of triple therapy across all GOLD categories. This data is not from our country. It is from US Medicare data. The result shows that ICS-LABA was the most prescribed maintenance therapy overall. Use of triple therapy was observed across GOLD 1 to 4, even in patients with mild to moderate disease, that is against the recommendation. And overall, ICS-containing regimens were used in 65 to 70% of the patients of all categories. Even the mild category of the patients were also receiving ICS-containing drugs in 65 to 75% cases. Again, this is against the recommendation, against the guideline. Now, new evidences or guidelines also says the use of biomarker in chest radiology to better characterization of the patients with COPD or better phenotyping, because biomarkers helps to construct the clinical and laboratory profile, allowing the proper choice of the treatments. These are the biomarkers used in COPD: the C-reactive protein, blood eosinophil count, sputum eosinophils, quantitative or volumetric CT thorax. So sputum and blood eosinophil count predict ICS response. So blood eosinophil, which can be measured very easily by any doctors. And this should be used as a very good marker or a biomarker whenever thinking about the use of ICS. So blood eosinophil use has to be practiced by all the physicians. Now, currently, a number of COPD phenotypes have been identified, which we must know. As you can see in the screen, there is asthma COPD overlap phenotype, frequent exacerbator phenotype, rapid decliner phenotypes, COPD with predominant emphysema, COPD with predominant chronic bronchitis, COPD with comorbidities, COPD with obstructive sleep apnea, that is overlap symptoms, and so on and so forth. So there are different or several COPD phenotypes there. So it is important to identify the clinically relevant phenotypes of COPD for early optimization of more personalized treatment. And right treatment should be directed to the right patients. Thank you very much. Now our next event is guest lecture, for which we have Dr. Apar Jindal. And I'm very glad to introduce Dr. Apar Jindal. Apar Jindal is MD Gold Medalist in Respiratory Medicine. Dr. Apar Jindal is the Clinical Director of Lung Transplant, Interventional Pulmonology and Chest Medicine at MGM Healthcare, Chennai. He has expertise in lung transplantation, managing advanced lung diseases, bronchoscopy, endobronchial interventions, and medical thoracoscopy. In fact, I should say, whenever the question of lung transplantation comes in the mind, always the image of Dr. Apar Jindal first comes in the mind. Amongst the pulmonologists, I can assess that, including myself, before a few years ago, we have a very little idea about the status of lung transplantation in our country. But it is Dr. Apar Jindal who made it clear about all angles of the lung transplantation and the status of or scenario of lung transplantation in our country and all over the country. So everywhere, whenever any pulmonologist or any physician now think about lung transplantation, and the best lung transplant pulmonologist, always the image of Dr. Apar Jindal comes. So welcome, Dr. Apar Jindal. And another thing is Dr. Jindal has special interest in the sleep medicine as well, and is a recognized authority in treating snoring, sleep apnea, insomnia, and other sleep-related issues. He has authored numerous national and international papers and is a preferred faculty for all major respiratory critical care and sleep medicine conferences around the world. He is a founder member of the Southeast Asia Society of Sleep Medicine, treasurer of the Indian Society for Sleep Research, and member of many other prestigious organizations. So I welcome and invite Dr. Apar Jindal to deliver your lecture. Now the stage is yours.
Sir, kindly unshare your screen. Stop sharing. Sir, please stop sharing.
So if you look at the top of the screen, there is an option to stop sharing. There is a red color button. Yeah, exactly. So,
sorry.
Thank you, Dr. Sarkar, for those action. I think it was very humbling. It was really great. And it's always such a pleasure to interact with you and be a part of any event that you host and that you organize. We have some brilliant speakers today who will be following my presentation. So a lot of responsibility here. But the good thing is your extensive presentation and your lucid presentation on COPD made my job very easy. So The topic that I'm going to talk upon today is the role of dual bronchodilator therapy. So even before I launch into my talk, what do I mean by dual bronchodilator is what we need to make clear for many people. When we talk about the most commonly prescribed inhalers, Buramate, Foracort, Symbicort, so these are inhalers which contain a bronchodilator, a beta-2 agonist, and an inhaled corticosteroid, usually which will be formoterol combined with budesonide. Budesonide or the ICS is not a bronchodilator. It is a controller medication, which is part of the combination which is prescribed. When we talk about dual bronchodilator, in my talk also, I'm going to be covering about the combination of two bronchodilators. One would be a beta-2 agonist, which we are commonly using, and the second would be a long-acting muscarinic antagonist, or a LABA-LAMA combination, as we talk it. So Dr. Shamil has given an extensive overview about the different aspects of COPD. What are the different categories, starting from A, B, C, D. He has told you about the step-up policies of the GOLD guidelines, how the management changes from a mild COPD to a moderate to a severe COPD, and what exactly are the indications, what is the group where ICS is recommended. So let me just go over some of the literature and some of the evidence, what we have, which professes the use of dual bronchodilator therapy. So if I can just get my slides to work, I'll start with a small case. So it's a 60-year-old gentleman who presents with disabling breathlessness and has a 20-pack year history of smoking. On spirometry, we find that the ratio is 0.5, FEV1 is 50% of predicted, and he has comorbidities with hypertension. As commonly done, he's prescribed an ICS LABA by the previous physician, but now presenting to me, he still has disabling breathlessness. He's not able to leave the house because of the breathlessness, while his echo, his KFTs, his LFTs, and his HbA1c is within normal limits. So the question is, what is the next step for this patient? Obvious thing is, what is troubling the patient most? At this point of time, if you start talking about a controller medication to the patient, he is not going to listen to you because he is disabled. He is troubled by the breathlessness that he is facing. And that is the most important point that needs to be addressed in this case. We also have data about it. If we look at the symptom burden in the Indian patient, and it's a beautiful study that was published all the way back in 2011, and it clearly shows that the most important symptom that needs to be focused upon is breathlessness. Almost about 80% of the Indian COPD will have breathlessness as their main presenting feature, which is very shortly followed by cough, which is present in another almost 60% of the patients. But mostly 80% of the patients have moderate to very severe COPD when they are first diagnosed with COPD. And other than that, breathlessness, exercise limitations, impaired quality of life, and high risk of exacerbations, you can see from this data, they form a part of the spectrum of disease throughout across all GOLD stages, let it be 1, 2, 3, 4. But we see these 4 symptoms, sometimes high, sometimes low, across all the stages of severity of COPD. So what happens? What is the problem with this breathlessness? It lands the patient into a downward spiral, which starts from dyspnea with activities. Now, because the patient, as we saw in our case, is not willing to leave the comfort of his home because of the fear of breathlessness. Subsequently, the patient becomes more and more sedentary to avoid these dyspnea-producing activities. Thereby, his activity level comes down. Finally, it ends up in deconditioning, which aggravates the dyspnea further by the weakness of the respiratory muscles, and the patient adjusts this by further reducing his activities. So this spiral is what the patient gets sucked into. Now, let's go back and look at what the pathophysiology of this entire process is. So with the inhalation of these noxious agents like cigarette smoking or pollutants, there ensues a damage in the lung at different levels. Simply, it starts with something like mucus hypersecretion, which is seen more commonly in the chronic bronchitis phenotype. There is small airway involvement with the airway narrowing and fibrosis, but mostly what we see is loss of the alveolar attachment and decrease in the elastic recoil, which is the emphysematous phenotype of COPD. But ultimately, all the three put together lead to obstruction and airflow limitation. Now, how does it feature into the clinical spectrum. We've seen the pathophysiology. How does it enter here? Because of the inflammation and the oxidative stress, there is expiratory flow limitation. Now, the alveoli get more and more distended with the air which is there, but because the bronchus, because the exit, the conduit which is taking the air to the alveoli is now narrowed or closed down in certain cases because of the mucus, because of the fibrosis, or just because of the extreme contraction of the smooth musculature there, it leads to hyperinflation, which adds to the dyspnea, and then further starts the spiral that we saw of inactivity, deconditioning, further decrease in the quality of life, and ultimately leading to death. Now, a special point of mention over here is exacerbations, which adds on to the severity of this expiratory flow limitation and then also adds on to dyspnea. Thereby, to prevent this expiratory flow limitation, the use of a bronchodilator becomes pivotal in the management. So how that works is it leads to the deflation of the alveoli, decrease in the dynamic hyperinflation of the lung by allowing the air to come out. Thereby, it leads to an improvement in the flow, which is represented in the PFT by an increase in the FEV1 and improvement in the volumes, which is seen in the FVC and the IC values. So what are the patient perspectives? So this was a questionnaire-based study which was done for the patients of asthma and COPD, that what are their fears? What are their perspectives about the disease? And we see over here very nicely that 53% notably reduce physical activity for fear of breathing difficulties. 60% have difficulty in walking up the stairs or walking due to COPD. 54% are afraid of COPD worsening as the cold season comes. Because of COPD, 23% feel that they are a burden to the rest of the family, and that's a very important point. And 37% are always afraid of not having the medicine for COPD with themselves. So this is the burden of what the patient feels when they have COPD. The important point about this, why the burden goes on adding, and Dr. Shyamul explicitly told us about the burden of COPD in India, is because of the delayed diagnosis. There was a survey done with 47 pulmonologists and data obtained on 247 newly diagnosed COPD patients, which showed that the first time a pulmonologist sees a COPD patient, the patient already has severe stage COPD. Thereby, what we come to know is that the physicians and the general practitioners are the first point of contact for all these patients for all their health-related issues, including COPD. Thereby, the need to identify, the responsibility to identify COPD in the early stages lies mainly with the physician and the general practitioner, because the early diagnosis and the subsequent appropriate pharmacological therapy helps in reducing the morbidity and mortality of COPD. We can see that 90% of the GPs and physicians and 82% of the pulmonologists already see the patients in moderate to severe stages of diseases. Now, coming back to the breathlessness, we have again seen from the patient perspective that breathlessness or varying degrees of breathlessness are present throughout the spectrum of the GOLD criteria of COPD severity. In a real-world study of patients with COPD, on maintenance therapy with single long-acting bronchodilator therapy, we see that breathlessness is not appropriately controlled. So majority of the patients were still breathless, and more effective bronchodilation would be beneficial. That is what most of these patients desire. Therein, the talk about combining the LAMA to the LABA should be addressed, with or without ICS, which is a separate question and will be handled separately. So this is a blow up of the box that Dr. Shyamul has already shown you. And I'd like to spend a few seconds or maybe a minute on this. This is one of the most important slides that I'm going to present in my talk. What is the place of a LAMA, or what is the place of ICS? So this is when we are talking about a patient who is already dyspneic while on LABA, or a patient who's had an exacerbation while on a LABA or a LABA-ICS combination. Here, the treatment or the therapy starts with the addition of a LAMA. You can also add an ICS over here, and then you need to investigate for the other causes of dyspnea if the patient is further deteriorating. And in case of an exacerbation on a LABA or a LAMA, you combine the two together And you can also add in an ICS if the points to consider over here are the patient has an eosinophil count of more than 300 or an eosinophil count of more than 100 with 2 moderate exacerbations or 1 hospitalization in the last year. So moving on to that, what is the need of this dual bronchodilation? So given the complexity of COPD, is it possible that the single drug may not possess the necessary pharmacological activity to result in the desired therapeutic effect? In patients not fully controlled with one long-acting bronchodilator, maximizing the bronchodilator with another type, another different mechanism of bronchodilation is the preferred approach. So when we're talking about the mechanisms of bronchodilation, let's look at what type of bronchodilations do we have. When we talk about the beta-2 agonist, which is the commonly used method of bronchodilation, we see how it acts. The beta-2 receptor agonist binds to the beta-2 adrenergic receptor, and this starts a cascade with the ATP converting into cyclic AMP and further down leading to an active pKa causing relaxation of the smooth muscle. Whereas when we talk about a long-acting muscarinic antagonist, it blocks the binding of acetylcholine to the M3 receptor. I'm so sorry. Thereby inhibiting the smooth muscle cell contraction. So these are two different mechanisms that we are targeting, two different approaches that we are seeing for the control of bronchodilation in these COPD patients. So how does the role of LAMA and LABA combination fit here? The cholinergic activity mediated bronchoconstriction is the major reversible component in COPD. So the increased bronchodilation due to the synergistic action, because the LABA is targeting a different receptor, the LAMA is targeting a different receptor, and this addition provides more bronchodilation, thereby giving a good relief to the symptom of breathlessness in these patients. So which bronchodilator should be given to the patient? How will you choose this? And the big question over here is, will you give a once daily bronchodilator or will you give a twice daily bronchodilator over here? So we have two very good combinations available now. An older combination, which was a combination of indacaterol and glycopyrronium, which has been used for many years now. And now the new combination, which is available with the combination of formoterol with glycopyrronium. So which one would you choose? Indacaterol being a once daily beta-2 agonist, ultra long acting beta-2 agonist, or would you go for a formoterol and a glycopyrronium combination, which can again be used once daily or twice daily, depending upon the dose? So how do you choose? An important point to choose over here is the presence of nighttime or early morning symptoms. You see, about 33.4% of the cases have early morning symptoms, and about 27% of these cases also have nighttime symptoms. Thereby, it makes sense that once 60% of your patients experience a lot of symptoms towards the second half of the day, it makes sense to split the dose and give one dose in the morning to control the daytime symptoms and another dose in the evening or night to control these nighttime or early morning symptoms. So what are the different agents which are available? If you look at the evolution of these therapies from the 1960s to the 2000s, you see that we have come all the way from salbutamol to the addition of ipratropium to salmeterol, and then so many new drugs came with the combination of formoterol, budesonide, tiotropium got added, levoalbuterol came, and now the two drugs that we are focusing upon is the combination of indacaterol glycopyrronium or the combination of formoterol with glycopyrronium. So what do we do about this? What evidence do we have about this? And for this, I'd like to bring into account the 4 Pinnacle studies, which were the long-term studies evaluating the safety and the efficacy of the combination therapy of formoterol with glycopyrronium across the globe over a period of time. So these were studies which were carried out on moderate to severe COPD patients and finally led to FDA approval of this molecule. Now, what were the major findings in these studies? And I'm not going to spend too much time over here. I'm just going to quickly go through them. Basically, the combination resulted in significant improvement in the inspiratory capacity as compared to tiotropium and as compared to placebo. So definitely, the glycopyrronium part of the combination with formoterol was better than the tiotropium part of it, because the inspiratory capacity was greater following the evening dose as compared to the morning dose. The onset of action of glycopyrronium formoterol was observed at 5 minutes post-dose. So therefore, the onset, which was defined as the first point at which the difference compared with placebo from the baseline, and a rapid onset definitely means better control, which would convert into an improved treatment adherence. This also led to a better improvement in the quality of life as compared to monotherapy or therapy with just a beta-2 agonist with or without NICS. And then ultimately, it led to the clinical benefits, which was seen in the symptom scores of these patients. Glycopyrronium and formoterol combination also resulted in greater improvements in the morning pre-dose of the trough FEV1 values versus monotherapy and tiotropium throughout the 12-hour dosing interval. So to summarize, the results of the Pinnacle study actually summarize my entire talk, which says that improves lung function greater than placebo, glycopyrronium, formoterol, and tiotropium. Has a rapid, the combination I'm talking about, has a rapid onset of action. It improves the morning inspiratory capacity. It reduces breathlessness, the most important part in COPD patients. It improves the quality of life, is effective in highly symptomatic patients. It reduces the use of rescue inhalers, and it does not cause any major adverse effects or cardiac side effects even after 52 weeks of therapy. With that, I'd like to end my talk, and I'm open to take any questions as the case may be, or towards the end of the day. Thank you so much.
So kindly unmute yourself.
Please unmute yourself.
Thank you very much, Dr. Apar. It's an excellent talk. You have given a very good overview regarding the of the pathophysiological changes and the correlation with the pathophysiology from the clinical symptoms. And you have described all the pharmacological molecules in details with a very good correlation to where it has to be given in which clinical situation and what are the study results. It was excellent, no doubt. It opens, it almost, results in answer the every questions everywhere. But our next program is how this information is translated to clinical practice again, and for which I will invite Dr. Prashant Kumar to present a clinical case here. Dr. Prashant is Senior Consultant and Director of Respiratory Critical Care and Sleep Medicine Department of IQ City Medical College and Hospital, Durgapur, West Bengal. So I welcome Dr. Prashant. Please present your case.
Good evening, sir. Thank you very
Now the
much.
stage is yours.
Thank you very much. I'm just trying to share my presentation.
Share screen is seen in the green color at the bottom.
Right, sir. That I can see. But after that, sir, after that, I just put it there.
Share screen. If you just click the share screen at the bottom.
Then the iPhone, iPad option comes.
iPhone, iPad option.
Prashant, there is an arrow by the side of share screen. If you just click on that, it will show you all the different options over there. Just your presentation, click on the presentation and it will work.
It's not showing. Microsoft Drive, Google Drive. That's a problem.
You are presenting
One
through a
second, one second, one second.
Okay, okay.
I got it. Perhaps I think I got it.
Prashant sir, if it is difficult from your end, I can share your presentation from my end also. So
One second. I'll just
Yeah, yeah.
It is on. So the share screen should work, right? Yeah, you can do that, please. Thank you very much. One second. It has come. Yeah.
Yes, sir. It's coming
Yes,
now.
thank you very much. Yeah, sorry for the goof up. Actually, now thing is that, sir, good evening. Thank you very much for and you have given an elaborate Sarkar sir and Dr. Apar Jindal also. So all the studies and all we have been going through last 6 months. I think if you are talking anything other than COVID is has to be glycopyrronium. So that's what I realized. So glycopyrronium we have also spoken a lot about, and then we have been put it into use in different forms like the respules and all those things. And we have definitely let me tell, glycopyrronium we were using since long time, but the new combinations, the BD combinations, the respules, all those things have in last few months perhaps have been widely used, and in my experience, it has really given good response. So all the evidence, we totally agree with it, all very practical, and it has shown results as well. It also matches with the results which we get in our practice. Now, my responsibility is to discuss one of the case, which is also one of the very dear friend of mine, and just that he's perhaps 30 years elder to me. But then we meet as friend. He calls me, I call him, and then because he was perhaps one of the first patients of COPD who came into very bad shape, and then he's living a very good life. So I always, I'm very fond of discussing his case to other people, because that's a real example of how COPD patients can do really well. Because otherwise, COPD is kind of a hopeless disease as long as patients perceive it, and to an extent, even doctors perceive. But then let me tell you briefly. So we'll just go in by the mostly practical things, how it came, what happened, and I'll try to squeeze in the time given. So now, uh,
Sorry to interrupt you, sir, Prashant
Yeah.
sir. It
Yeah.
will be great if you do a full screen. So it is just adjacent on the lower end, adjacent to 69%. So there is one icon, you can click on it. So sir, you have to. Okay. Yeah.
see now?
Great, sir. Thank you. Yeah. Great, sir. You can go ahead.
Thanks, sir. So a 69-year-old a gentleman comes with 40 packets of smoking. He was working in one of the industries here. As you all know, Durgapur is heavily industrialized, at least in initial days. Now industries have come down, but earlier it was heavily industrialized. With on top of that 40 packets of smoke, and he was diagnosed by one of the physicians with COPD 10 years back. Initially, he was put on levosalbutamol and ipratropium. I think that combination is the most widely used combination if we are not using ICS in India. So, and then he was put on that. And he used to take that multiple puffs after puffs. He never had he did not know how many puffs he takes. So if he goes for a walk, he goes to market, he keeps taking puffs. If he's breathless at any other activity, he takes puffs. So multiple puffs of levosalbutamol and ipratropium. So he was he had given up. He was like, now I cannot even walk to market. And if I tell you an interesting fact, in West Bengal, people like to go to market. They just love. When I was in other metro cities like Gurgaon or Bangalore, uh, we never liked to go to market. People never liked to. They wanted the things to reach to them. But then here in West Bengal, everyone wants to go to market. So he was very disturbed that I cannot even go to market. So he used to have, and on top of that, he used to have 2-3 exacerbations per year. So, which obviously he was always scared of doing things, going somewhere, visiting relatives, or maybe holidays. And another fact about West Bengal is people really like to go on holidays. You see, most of those waitlist tickets is because of the people of the West Bengal. We book it in advance, that's why you get tested. This is what I have observed in last 4 years, which I'm spent here. So I'm sure everyone will agree here who belongs to Australia. So he used to have 2-3 exacerbations per year. He was scared of going out. He was scared of going for a holiday. You'll see good, very fond pictures of West Bengal family, full family, with a 70-year-old father and son, wife, kids, everyone going to a Kashmir holiday or a Himachal holiday. So he always used to miss that, and then he was always scared if I go there, I may not come back. Then he was hospitalized 8 times in last 10 years. That is a big ordeal, although financially he was covered by his company. Although financially he was covered by his company, but then uh, this definitely hospitalization took a good toll on his mental strength also. And his symptoms kept increasing over the years. So finally, I moved to Durgapur in January 2017, and then this gentleman visited me March 2017 for one very known reason that I was coming from Bangalore, and someone said, "Ki, there's a neurologist who is from Bangalore." So people of East India is really fond of doctors from Bangalore and South India for that matter. So he came and visited me if I can help him. So like routine chest X-ray, emphysema, nothing significant, nothing new. And then got a spirometry done with the P1 of 34%, obstructive airway disease, severe kind. So this obviously, by the history itself, we could make out okay, what is the situation. And spirometry in COPD patients, this is what mostly get in this advanced COPD in our area. Most of the patients have these kind of picture. So spirometry. Easy to diagnose him as severe COPD. Then treatment, he was started on, excuse me for my spelling mistake, he was started on ICS plus LAVA, the most used combination. How much ever we talk about other combinations, but ICS LAVA, as long as inhalers are concerned, is the most used one, I feel. And for some reason, it gives good response to patients also. Initial. Later on, that becomes static. This is what we have. If patient was taking only a short-acting ones or other inhalers, infrequent dosing, then you put patient on ICS and LAVA, patient definitely feels better for a while. But then again, you will realize that you have hit the plateau. Patients are not feeling better beyond this. Patients are still having expectoration. Patients are still that you are coming with exacerbations. This is a strange finding which I realized. Initially they are, oh, gaga over it, oh, you have given me a new life and all those things, but then it does not improve beyond a point. And then he was put on ICS and LAVA and SABA and SAMA, SOS, NDI, whenever he required. So he used lots of SABA and SAMA also, along with ICS and LAVA. But his activity level improved within 1 month. That's what I mean to say. ICS LAVA combination definitely does some good to Indian patients, as I understand, even in COPD patients, they do it. So after 1 month of treatment, he started his activity level increased, and he started feeling good. And but then he had within 1 month he had one episode of increased expectoration, although it did not reach to an extent of calling it exacerbation. But then he was expectorating a lot for good for 4 to 5 days, and he was given antibiotics again, and then that settled down. So there was some change in his sputum production after starting of ICS LAVA. I don't know. He was also not very comfortable with multiple doses. So he started feeling better, but then he was not completely better. Perhaps he did not reach the level where he wanted. The first month he was very happy because he improved from where he was. But then could not continue that improvement for a long time. Hence, he came back again, asking for something. Maybe perhaps he got a little hopeful to the treatment, and he asked if we can offer something else. So in April 2017, he was put on indacaterol and glycopyrronium once daily at dosing, and levosalbutamol. Now, when uh, when indacaterol glycopyrronium was put, his sorry, excuse me for my spelling. His expectorations came down, became minimum by the July. So April, May, June, July, say 3 months from then. Excuse me. So his expectations came down, became minimum by July 2017. He started going to market. One of his worries on whether I will be able to go to market or not. And in September 2017, he went to holiday in Arunachal Pradesh, which was perhaps approximately 13,000 feet from sea level. So, Seki, after starting with indicator glycopyridine in April, by September of the same year, that is good 5 months from then, he could do whatever he was expected to do at this age. So definitely this improved his life, this reduced his exacerbation, and overall a patient of frank COPD, a severe COPD patient, really started feeling good on this treatment. Just very simple, easy to go because once daily dosing and levosalbutamol whenever he required. He gets few mild exacerbations per year. Still, he gets exacerbations, but they are milder. But he was never admitted since 2018. So that is another thing. See, another one quality which all the COPD patients should have, COPD drugs should have, is that they should reduce the chance of exacerbations. So one drug which reduces the chances of exacerbation, or for that matter, they really reduce the chance of they really reduce the rate of exacerbation. And that is the drug for COPD. That's what I understand. So this also proves that this is the drug which really reduce the exacerbations within 4 to 5 months of treatment. So now that was a brief thing about that. If you ask me for a repeat spirometry in COPD patients, I don't like doing it because it does not change. Although they improve clinically in the sense symptom wise, but then they don't improve spirometry wise. That's why I don't like to repeat spirometry in COPD patient because if you even of 32% after good 6 months of good treatment, patient improve well can become just 34%, and that really puts the patient back. Then it may then 2% increase हुआ है करके and then mentally he is like not feeling good. That's why I don't like repeating COPD in patient. Asthma, yes. Patient comes with 40% FeV1, you give good treatment, it can reach 80% very soon, and then the patient can also feel good at the same time. So now let's discuss few things. So please interrupt me if I'm taking too long.
Now, I think Dr. Prashant,
Right, sir.
You conclude here, and further discussion will be better in the panel discussion.
So yes, right. So spirometry, I don't like to repeat. Indicator glycopyridine is a wonderful combination for good amount of COPD patients. Although it tends to help lots of moderate kind of COPD patient, but even in severe COPD patient like this gentleman, it has really helped. Once now the discussion will come whether to give in the morning or in the evening. That is very subjective. Someone needs in the morning. Someone who is active will require it in the morning because they are active during the daytime. Someone who is not active during the daytime can very well give in the evening time, so that it can reduce their nighttime symptoms, which really bothers them. Nighttime symptoms are scary because they cannot call anyone. There's no one to help. So always we have to keep that in mind as well. So this is one short case history which I'm very fond of this case. I really feel that we have treated the COPD very well with this.
Yes.
So
thank you very much.
Yes, sir. I give back to you sir.
Yes.
Good, I'm done with my case.
Yes. Thank you very much, Dr. Prashant. Indeed, it was a very good case, and we experienced this and treated this very well. And the patient was able to go to the Arunachal Pradesh, 13,000 feet high. So it was a great achievement for the patient as well.
I just wanted to tell one more thing, sir.
Okay.
So this used to be a little expensive drug earlier. Now it is cheaper drug. So earlier it was approximately 2,500 rupees per month. That was.
So we will now you will get the opportunity. We'll give you a special comment during the panel discussion. Yeah. We have certain important questions and regarding the molecule, regarding the clinical setup. Okay, we will discuss it in detail during the panel discussion because there is sort of time here. So thank you very much, Dr. Prashant. And now we will start our panel discussion. Actually, we have sorted out several questions clinically important question, and which we face in our daily day-to-day practice while treating COPD patient. And for the discussion, I will invite our two expert panelists. One of whom is Dr. Anil Agarwal, who is DTCT and MD in pulmonary medicine. Dr. Anil Agarwal is Senior Director, Medical and Health Services, Bokaro General Hospital, Bokaro Steel City, Jharkhand. Welcome, Dr. Anil.
Thank you, sir.
And,
Good evening.
Welcome. And we have second expert panelist, Dr. Abhishek Kumar. Dr. Abhishek Kumar is MD in chest medicine. He is consultant pulmonologist and attached to Paras HMRI Hospital, Patna. Welcome, Dr. Abhishek. Dr. Abhishek. Dr. Sachin.
Yes, sir.
Please give video of all our panelists, Dr. Prasanth, everybody should be seen in the screen. Everybody seen in the screen.
Dr. Abhishek, I think you need to start your video and unmute your mic.
Dr. Abhishek.
Yeah.
Sir, Abhishek, sir, please unmute your mic.
Dr. Sachin, everybody should be seen. Na? Everybody should be seen in the screen.
Yes, sir.
Yes. I am audible, sir.
Yes, sir. You're audible.
Okay, thank you.
Shamal, sir, we can start now.
So we can't see everybody here in the screen. You can see me.
Yes,
Yes,
sir.
sir, I am seeing.
Yes, sir.
Yes.
Yes.
Okay. So we'll start our few important questions we will discuss here. As we come to know that long-acting bronchodilators are the cornerstone of treatment of COPD. Now I would ask Dr. Abhishek Kumar. So
Yes, sir.
So where is the place of long-acting bronchodilator monotherapy in the maintenance treatment of COPD?
Actually, sir, if
When
the
you will
patient
be-
is on treatment of the LAMA or the monotherapy, if he's stable, then we can continue for LAMA. Hello.
So whether we will give LAMA or LABA?
We can give the sir LAMA or LAMA anywhere. But if the patient is not, hello.
Yes, we are hearing you. And another thing,
If the patient is not,
yes.
no, the symptom is not maintained with the LAMA, then we can add the other therapy with LAMA or LAMA.
Okay, but which will you prefer? I am asking about LAMA or LABA. Which will you choose and why? So, in any discussion in this, any questions, any of us can give any comment or can add anything if you want. Dr. Apar, Dr.
See, one problem that we
Ani?
face,
Yes.
sir, is that LABA alone is usually not available. Earlier studies, the studies which were published early on, right from the time of Torch, it was clearly shown that LABA monotherapy actually increased mortality. So most of the combinations which are available commercially is a LABA and an ICS combination, rather than having LABA separately. It was only when Indacatrol came out that started to appear as a single LABA therapy. But that again was used as an add-on therapy to the existing LABA-ICS combination used for severe asthmatics. So once we're talking about a monotherapy in COPD, I believe that you're talking about the group A, category A patients, or the patients who have mild COPD or moderate COPD and are very well controlled with that single inhaler. So at that point of time, either a LABA ICS combination, but definitely a preferred would be to start a LAMA therapy right at that point of time.
Yes. So right about we have to choose the monotherapy. LAMA is the better. Now we have two LAMA at the present moment. The old one which we are using, that is tiotropium, and the new molecules we are using nowadays, glycopyrronium. So among these two, which will be the better and why? So what is the difference between glycopyrronium and dialba, and what you will choose? So again, Dr. Abhishek, you can answer this question as well. What is your experience? Dr. Abhishek?
Both the glycopyrronium and tiotropium, we prefer tiotropium because the selectivity of the M3 anticholinergic 3 muscarinic receptor is good for tiotropium. And the tiotropium increase the exercise capacity and also decrease the dyspnea scores. But also the tiotropium is cheaper than the glycopyrronium. And in the multiple in study multiples, the glycopyrronium and tiotropium both are equivalent for the exacerbation, reduced exacerbation, and the dyspnea.
Okay. Okay. Anybody can?
You need to unmute.
Want to add
So
anything here?
glycopyrronium will be a touch
Regarding,
better. Will be a
what will
touch
be the
better.
choice? Glycopyrronium.
Glycopyrronium will be a touch better because it is more selective, faster in onset, and then lesser side effects. So perhaps glycopyrronium is a better molecule. Only thing is that it only comes in the powder form. So that can be one of the. But then it is also available in rescue form. So that is another advantage. So it depends where you want to use it. The way you want.
So as far as pharmacological efficiency or the action, glycopyrronium is better because of rapid onset of action. Yes.
More selective,
rapid
less side
onset,
effect.
and sustained and more selectivity for the M3 receptor blockade. Side effect profile is also better than tiotropium, more cardiac safety. So considering everything, if the patient can afford, so glycopyrronium will be the better molecule. Yeah. Yes. So next question will come Dr. Anil. So have been already discussed about the dual bronchodilator. What is the rationale? Why you will choose dual bronchodilator particularly? In short, can you say? What is the basic rationale between these two?
Sir, as already has been spoken by Dr. Jindal and Dr. Prashant, that bronchodilators remain the cornerstone of COPD management and the first line of management. Combination of different mechanisms of action is always more effective than a monotherapy. A combination, the studies have shown that a LAMA-LAMA combination, they improve the lung function, they improve the dyspnea score, the total dyspnea index, they improve the overall health status, the overall quality of life, and mainly they decrease the exacerbations. So these are the 4 important benefits that we get from a dual bronchodilator, that is the LAMA-LAMA combination, and both with a different mechanism of action, they act synergistically.
Then what molecule you will choose as the better? In case of LABA or LAMA, which molecule you will consider the best for the dual combination?
Indacaterol and glycopyrronium is the most widely used with the good results. They are in the market for last 3 to 4 years, and the combination of both, they maximize the bronchodilation by combining 2 effective, and both have 24-hour bronchodilators effect. So both have a different and a complementary mechanism of action. So both combined together give a good result, and they are definitely more effective than monotherapy with either of the 2 drugs.
Okay. So in the market, there are other 2 products that are also available, like Glycoformo, as mentioned by Dr. Apar, and also a combination with formoterol.
Formoterol is also available.
So how will the synergistic action amongst these 2? What is about your opinion regarding the synergistic action of this combination?
synergistic action of the combination.
Yes. Is it equivalent to?
No, the glycopyrronium based combination is better, and the studies have shown that glycopyrronium have set to increase the inspiratory capacity, which shown by the slides of Dr. Apar. And since inspiratory capacity is inversely correlated with the dyspnea score, especially with exercise, so glycopyrronium scores over tiotropium in that case, and a glycopyrronium based combination is superior to a tiotropium based.
Yes.
In the onset of action, the 24-hour efficacy is better, and so this combination is a better one as compared to a tiotropium based combination.
Okay. Now, actually, whenever a dual combination is prepared, that molecule should have a compatibility with each other, and the molecule will also should have a regular equal duration of the action. So whenever you are giving glycopyrronium can be given in the PID dosing, and formoterol can be also be using in PID dosing. So their molecular mechanism, their pharmacokinetics, their duration of action is matching. So give better synergistic action. But the tio and formo is rational. Its combination seems to be an irrational. One is 24-hour action, another is 12-hour action. So this combination, to some extent, is not rational. So synergistic action definitely will be better with the glycoform space. Now, Dr. Abhishek, I want to ask another question here. Dr. Abhishek.
Hello, sir. Yes,
Hello?
sir.
Yes. So,
Hello.
So gold guideline says that whenever the patient is not controlled with monotherapy, you have to step up to double therapy, dual bronchodilator therapy.
Yes,
Now,
sir.
in which situation we can start directly the dual bronchodilator therapy as an initial drug of choice? So, in which clinical situation you will like to start a dual bronchodilator therapy at the initiation of the treatment?
In the board guideline, there is the beautiful presentation by the criteria A, B, C, and D. So the dual bronchodilator therapy is most really if the patient has a more exacerbations, frequent exacerbations, more hospitalization, then that time bronchodilator therapy is the more efficient. C and the D is the most preferred patient for the dual therapy.
Okay, so it can be used as an initial therapy in group B, group C, as well as in group D.
Yes, sir.
Yes. Thank you. Now, the COPD patients shows circadian variability in their symptoms. Many patients has most predominant daytime, many patients have nighttime symptom as well. Now, Dr. Prashant, can you tell me which are the most disturbing or severe symptom that must be targeted for the proper control? Daytime symptom or nighttime symptom or early morning symptom?
So, sir, like I said earlier also,
Yes.
we need to segregate our patients. Someone who is working during the daytime, then the daytime becomes the most important part of his life. He should not be breathless while working. He should not be breathless while he's out of his house. So all those things we have to keep. But then someone who is staying at home, say post-retirement patients, their nighttime symptoms are more scary for them because they feel it can be heart attack, it can be so many other things. No one is there to help. Hospitals must be closed by now. Doctor is not available. So nighttime symptoms control for those kind of population and daytime symptom control for an active individual. Now you see the age of COPD is decreasing. I mean, in the sense at earlier age we are finding to see COPD most often. So we have to keep, if someone is working active during the daytime, then I would prefer to keep the doses in the morning. A long acting, if I'm giving a 24 hours drug, then if the patient is elderly and then they feel कि nights में sometimes they get scared because they report to OPD next morning. Like sir, रात में ऐसा हो गया था, वैसा हो गया था. I tried your phone, you did not pick, things like that because we may not pick every time. And then I contacted your assistant, he was not picking. So that's a scary feeling. The first thing in the morning, 8 o'clock is there sitting in your OPD. So in those kind of patients, nighttime. But then, sir, this is very, very subjective. It depends on the doctor or the patient. So there's nothing. But the nighttime symptom control. So the BID dosing of the drug, that's where it may come into picture. If you have something where you need a good control throughout the day or throughout the night, then the BID dosing. Otherwise, if someone is stable, not showing any particular time symptom, then I think once daily dosing also suffices.
Yes. So once daily dosing is sufficient. It can control well good data. If the patient has significant diet symptom, then he will prefer dual dosing. This is his answer. Okay. Now I'll ask Dr. Apar a very important opinion from you that in dual bronchodilator fixed dose combination, there is always a concern about the potential additive cardiovascular toxicity of LABA and LAMA. Both of these molecules have cardiovascular toxicity. What is your experience and opinion regarding the safety profile in the high-risk cardiac patients? This is particularly, again, very concerned about the cardiologist colleagues. They don't want to use the long-acting bronchodilators or like that in their cardiac patients also. So what is the safety profile regarding the cardiac safety of these molecules? Please give your opinion, Dr. Apar.
Yeah, when we're talking about the cardiac safety, so I would say as we have moved from the shorter acting to the longer acting drugs, gone from ipratropium to the use of tiotropium and now to the use of glycopyrronium, I think the cardiac safety is going on increasing. We see much less cardiac actions with tiotropium and then further less with glycopyrronium because the selectivity of these molecules to the M3 receptors is going on increasing. Drug like ipratropium, which is non-selective and would bind to M2 receptors also, would give more of cardiac effects of tachycardia and other arrhythmias. Whereas it will be much less when you look at it from the angle of a glycopyrronium or a tiotropium combination. Now, between these two drugs also, glycopyrronium being a touch more selective as compared to tiotropium, we would expect a little less cardiac activity over here or cardiac side effects with glycopyrronium as compared to tiotropium as well. And, if you look at my practice per se, if I'm to give anecdotal personal experience, I see the sickest of the patients. These are the patients who are already in chronic respiratory failure and have come to me for lung transplantation now. And most of my patients, especially the ones who've come from the COPD spectrum, are on the indacaterol glycopyrronium combination or the formoterol glycopyrronium combination. And they always will have certain amount of cardiac pathology because of the pulmonary hypertension, because of the right ventricular strain patterns that all of them show. But having used glycopyrronium in them for a large number of cases, we don't see that much of cardiac toxicity here. So the longer acting ones, and especially the selective ones, I would say are much safer than the non-selective and the shorter acting drugs.
Thank you. And Dr. Prashant, I will again ask you, the patient uncontrolled on the dual bronchodilator therapy, what to do? What will be your approach to the patient?
So uncontrolled means that there can be two meanings to it.
Yes.
One who is getting into exacerbations, or someone just symptomatically not controlled. The patient is not going into the full-blown exacerbation, but he is not feeling that well. So in that situation, in case of this patient requires more bronchodilation than additional bronchodilator, maybe oral. Also, in addition to that, if I reach the maximum dosing of inhaled ones, and if patient is complaining of repeated exacerbations or few symptoms which may force me to give him a steroid in Indian context, because we see lots of patients in India particularly, they respond very well to ICS. So there's some background of maybe the pathology which tells us that perhaps ICS may work better in India in Indian population compared to other countries. ACOS is very commonly seen in India because most of the patients, they have this overlap syndrome, lots of overlap syndromes you'll see. Eosinophil count, I don't know how to go about it because most of the people will show some kind of elevated eosinophil count, some other features like that because of other reasons other than some reasons other than what we actually want to concentrate
So
on.
in that situation, actually patient is already in dual dual bronchodilation. So now, if we want to step up to triple therapy, in which situation you will add ICS, and in which situation it will not ICS. So tell me or give some idea for adding ICS and not.
So eosinophil count, like I said, sir, eosinophil count is one of the cutoff we need to take, or more exacerbations. These are the things where you are bound to. But then if someone is already on dual bronchital, what option do we have? You have to use an ICS.
I'd like to add something over here. So when we are dealing with a patient who's already on dual bronchodilator therapy and still not doing well, he's either not symptom control or still showing exacerbation, before we go on to add more therapy to him, either in the form of an ICS or in the form of an oral bronchodilator, as you mentioned, there are two very important things that we need to consider. And this is something that all of us do in a clinical practice. And this is something really important. One is check whether the patient is actually using the drug. So many of the times, these patients are not compliant with the therapy. They may not just simply be using their inhalers to the appropriate numbers that they need to be. And secondly, the way in which they are using inhalers. Now, if you talk about indacaterol and glycopyridine combination, unfortunately, this is a combination which is available only as a DPI. And if you're talking about a patient who is not symptom controlled and who's, again, frequently exacerbating, these are typically the patients who have a low inspiratory reserve. So how much of the drug is actually reaching into the up to the lower bronchus levels over there to give them adequate bronchodilation? So I think those are the 2 points that we need to address first. And after that, only once we've seen that this is there, the patient is compliant, and the methodology of taking the inhaler is appropriate, then we should think about going to another, adding another drug over there.
And a few more strategies like azithromycin twice weekly. They also, things like that, they also have shown some results. It's still yet to make it a regular use in our practice, but then we definitely use it in certain patients.
Shamal sir, you need to unmute your mic. Shamal sir, you're muted. You need to unmute your mic.
And one more thing I would like to add that before stepping up, the non-pharmacological treatment in the form of pulmonary rehab, adequate pulmonary rehab is very important before we go for a step up. We need to see for other comorbidities as well and treat them accordingly before stepping up.
Yes, correct. So these 3 or 4 things which have been highlighted, that the adherence to treatment, inhaler technique, whether the patient has stopped smoking or exposure to other triggers as well, and addressing comorbidities. So these are the important things which has to be addressed before thinking about stepping up of the or addition of the other drugs. Very correct. But where you should not add ICS, I want to know, particularly if the patient gives a history of multiple pneumonias, or if you find a very low eosinophil count, less than 100, or if the patient has no frequent exacerbations. So in these situations, absence of exacerbation, absence of eosinophilia, or having the history of recurrent pneumonia, this may be a certain situation we should think 10 times more before adding ICS. Now, Dr. Anil, what is SIT? SIT, that is in the COPD treatment, single inhaler triple therapy. What is your opinion about this?
There is single inhaler triple therapy, that is SIT, that is basically used for the group D patients, as already explained. And when our patients, the A, B, C group, they are not well controlled, they are exacerbating frequently, the guideline says that at least 2 exacerbations treated with oral corticosteroids, antibiotics, or both in the previous year, or at least 1 severe exacerbation that required hospitalization, or 1 exacerbation a year repeatedly for 2 consecutive years. So these are the 3 things of exacerbation or frequent exacerbations who need to be a step up in the group D patients. Apart from this, studies have shown that between 12.1 to 55% of the patients have ACOS, the asthma COPD overlap syndrome. Differentiating COPD with asthma can be difficult in clinical practice. So such individuals should be stepped up in group D patients, and they should be given the SITS, that is the single inhaler triple therapy regimen.
Bronchial asthma patient. Do you think is there any scope of using triple therapy in bronchial asthma patient?
Not the bronchial asthma patient. The ACOS
Any
patient,
scope of using this in the bronchial asthma?
where there is an overlap syndrome of
Not necessarily. In case of bronchial asthma, step 4, step 5, we are using inhaled corticosteroid. You are using LABA and also using tiotropium since long. So in step 4 and step 5 patients, there may be some scope of using this triple ICS. ICS is, we are very much concerned about using ICS. Dr. Abhishek, can you tell us what are the possible side effects of using high dose ICS in this patient? Dr. Abhishek, unmute.
Sir, kindly unmute yourself. Dr. Abhishek.
Hello, audible, sir?
Yes. So what are the possible side effects of ICS? We are discussing about ICS. We are very cautious about adding ICS. So why so? What are the side effects we concerned about?
Most of the patient of the using the ICS in high dose or other frequently, they may present with the oral candidiasis and the change in the voice. And there are the subgroups of the something there may be the present with the frequent pneumonia. But this subset of the patient are really less. If there is a patient of the very low FEV1, age is more than 55.
Is there any other side effect?
Has the
Yes,
risk of the frequent frequent pneumonia. But these pneumonias are not a side effect, but the oral candidiasis and the change of bias is the main factor.
Is there any possibility of developing diabetes, cataract, or like? So all the side effects of corticosteroids can be developed. Yes, if we give inappropriately high dose of corticosteroid for a long time, so there is possibility of development of all the side effects we find in the oral corticosteroid as well.
This side effect of the
Can be developed. Now, as you mentioned the pneumonia, I want to know the experience of Dr. Apar. How frequently you see pneumonia as an adverse effect of ICS in COPD? Dr. Apar, please.
If you look at the data from the different trials, specifically if you look at the meta-analysis which was done from the COPE trial, from the COSMIC trial, and from the WISP trial, it clearly showed that withdrawing of the ICS was absolutely non-inferior to the use of just a dual bronchodilator. Wherein, if simply put, that showed that ICS was not adding value in the therapy of any of these patients. And in these same trials, it was clearly shown that this ICS in certain number of populations, it was definitely giving an increased incidence of pneumonias for the patients. So I would say that at least maybe around 7 to 10% of the patients will be such who will have increased incidence of pneumonias where ICS is regularly used, especially if it is used in the higher doses.
And particularly the elderly patients, it has been documented that elderly patient with very low body mass weight, less than 25, and who already has a history of pneumonia in the previously, smokers, and severely symptomatic with severe lung function declines. So, in fact, this is a subset of the patients, they are tend to develop the pneumonia. We must be cautious adding
one point that patients who are on regular ICS nebulized form, where we are giving higher doses, those patients are more likely to develop pneumonias. When we are giving in a DPI or a MDI form, the chances are much less.
Okay. Now, again, the patient is getting triple therapy with the ischias LABA/LAMA and still not properly controlled, having recurrent assistance system. From monotherapy, from dual there is no the comorbidities have been addressed, and the patient is adherent to it. It's taken not all having recurrent exacerbations or persistent symptoms. So, what to do in this situation? Dr.
I did not get the question.
Uh,
I think there is some issue with the connection from Dr. Sharma's side. So
yes.
if I can just intervene, I think the question that Sir was trying to bring out here was that once we have a patient who's gone from a monotherapy to a dual bronchodilator therapy, and then now maybe even on a triple therapy, if this patient is still not controlled well with the medications that we are doing, what would be the next step that you would like to take?
Pulmonary rehabilitation is one of the things which is a good, which we are not, due to our busy practice, we are not able to practice it full-fledged. But then that has really shown good effect. The patients who are chronically with us with the diagnosis of COPD, we do advise them about the exercises and the diets, and the maybe a crude way of doing pulmonary rehab till we actually open one of them. But then they have shown it. That is one thing which you can really advise the patients, and they may show good results. Then the vaccination of elderly about prevention of the disease, because if they go into the phase where they're hit by some infections or pneumonias, then they are really into bad shape, and coming them out of the intensive care, if they reach intensive care, it will be very difficult for them. So adult immunization with influenza and pneumococcal. So far, I mean, COVID is yet to come. So these two things, which I feel really, azithromycin twice a weekly, we have been using for some time. I don't know whether this lockdown has improved their function, or they're going to less of exacerbations, less pollution, less going outdoors, meeting infected people, or something. But then these are the few strategies which we really feel they can help. Motivation is one of them. They're very low. They know that they realize it perhaps that they're suffering for some end-stage lung disease, which cannot, because COPD cannot improve beyond the point.
What is the best of roflumilast here?
Roflumilast, sir, I think it's out of favor now. I don't think it makes much of a difference. I have not used it. I must have vaguely used it sometime, but I don't think it is favored anytime. So,
but still it has a place here, particularly in the chronic bronchitis phenotype, having severe lung dysfunction symptoms.
Possibly, sir, because I have not experienced. I have not used it.
So in this situation with triple therapy, ischias LABA/LAMA, and addressing the comorbidities with rehabilitation, with vaccination, with proper adherence to treatment, with proper inhaler technique, avoiding smoking, everything, and having no significant eosinophilia is in this situation. So definitely we should try or think about adding roflumilast, or adding azithromycin, or theophylline, or acetylcysteine. So these are some of the drugs which we can try in these situations, particularly in a subset of patients having chronic bronchitis phenotype and having a history of hospitalization with severe degree lung function dysfunction and symptom. There may be role of adding roflumilast in this situation, or particularly in the non-smoker patient or the ex-smoker patient, we can add azithromycin for the immunomodulatory action, and azithromycin in the dose of 250 milligram daily or 500 milligram alternate day. And it has been tried
It's 250 milligram
For
twice weekly,
1
right?
year
Sir? Twice
with a
weekly.
significant reduction in the
So
the dose is usually 250 milligram daily or 500 milligram alternate 3 days.
But I feel ki sir is 250 milligram twice weekly.
No,
In long term azithromycin.
no. So there are two protocols, so two schedule, either 250 milligram daily or 500 milligram 3 days a week. And this sort of treatment you can continue for 6 months or 10 months and see the results, particularly in the non-smoker or ex-smoker patients. So this is used not as an antibacterial. It is used here as an immunomodulatory treatment.
But then
And
giving
similarly,
azithromycin on high dose for a long period of time may have some toxicity, some cardiac
yes,
toxicity.
there are concern of 3 important points here. There may be development of the drug resistance, there may be development of the hearing impairment, or QTC prolongation. So these things has to be sorted out in each visit. So there is the chance of developing QT prolongation. So we should not give other drugs. We can also increase the QT interval. So QT prolongation, hearing impairment, these are the two most important things, and another development of the drug resistance. So these 3 things has to be kept and has to be dealt with in long-term azithromycin treatment. And there is definitely, we are using theophylline in each and every patient. We have a good experience in using theophylline. And definitely there is also a role of N-acetylcysteine in these patients. So this combination of all the drugs according to the specific phenotyping or particular situation, we can use this pharmacological treatment as an add-on therapy in this situation. Now, one important question comes here regarding dual bronchodilator is giving very good results. And we should use dual bronchodilator in all the cases because of its good results. But dual bronchodilator is available in the dry powder formulation. So here comes a problem. Can all the COPD patients use this dual bronchodilator easily or not? So the selection of the device. There is an importance of selection of the device in COPD patient. What is your opinion regarding this? Dr. Apari, you tell this.
So,
Dr. Apari, your opinion regarding this.
Actually, DPI does pose a small degree of problem, especially when you're talking about the severe COPD patients or the patients who've got a low inspiratory capacity because they're not able to take the drug properly. But fortunately now we have glycopyrronium was always available in the nebulized form, and now the combination of formoterol glycopyrronium is also available as a nebulizer. Plus, very soon we are also having the formoterol glycopyrronium also available as an MDI. So I think moving forward, these inhalers will be used more and more often. But till that time, indacaterol and glycopyrronium plus the formoterol glycopyrronium available in the DPI form remains to be the mainstay of therapy for the masses right now. And definitely, patients who have a poor inspiratory reserve will face a problem in getting this drug properly.
Okay, thank you. Now we have come to the last question for the discussion today, that is ischias withdrawal. So in which situation we will decide about the ischias withdrawal and what would be the de-escalation schedule? Again, you give your experience and your opinion on this situation.
So ICS de-escalation, as we've already seen, patients who do not have the risk factors, who are not exacerbating a lot, patients who do not have the allergic phenotype, that means the eosinophil count is low. If you've done a pheno, that is low. They do not have any symptoms or any features, any history suggestive of an ACO type of a disease. Or if you're talking about the at-risk phenotype, the elderly, patients with pre-existing lung disease, these are the ones who should be taken off the ICS once their disease activity is stabilized, once their symptoms are controlled. Because we know very well that LABA and LAMA are the ones who are going to do the job, and the ICS is not going to add more value to it. So that needs to be taken off. The problem is the inhalers is the same. Most probably we are going to either prescribe a LABA ICS combination and then another inhaler with a LABA and LAMA combination. The way to do it is let's half the number of actuations that you give for each inhaler. Say if you've given a LABA ICS with 400 micrograms of budesonide, 2 puffs twice daily for the patient to start with, or 200 micrograms with 2 puffs twice daily to start with, you can cut down the number of actuations that the patient is actually using. So ideally, we would like to half the dose of the ICS every 2 weeks, and then try to bring this dose down slowly over a period of 6 to 12 weeks. And if we are able to achieve that and simultaneously make sure that the breathlessness symptoms and the bronchodilation is maintained by increasing the dose of or increasing the frequency of the LABA-LAMA combination, the patients can be easily taken off the ICS.
Yes. So, in particular situation, it has ICS withdrawal can be done confidently, but the process is slow withdrawal. Abrupt withdrawal can result in re-exacerbation or reappearance of the symptom like that. So it is to some situation we can compare with the weaning off from the ventilator on BiPAP. So weaning on BiPAP like that. So wean from ICS on dual bronchodilation. We can assume this in this situation. So with this question, we have come to the end actually.
I could not complete my case, sir. Give me a moment.
Oh, okay, complete. Please complete.
Give me so the case I was discussing about. I cannot see the screen. Just disappeared.
Shamal, sir, you need to stop sharing the screen.
Yes. Yes.
The case I was talking about, he was on Indecatrol glycopyrronium, 2,500 rupees per month for 2 years. Then he comes to me. He said, I have 2 questions for you. I said, yes, please. So this is becoming very, very expensive for me. So I'm a retired person. I cannot continue it. So do you have an alternative? I started thinking of an alternative. Then he says, the second question is, my son stays in the US and can I go and visit him next month? I said, are you sure your son stays in the US? So he said, yes, sir. So I said, can you show me the ticket? That yes, he shows me an Emirates ticket to US. I said, no, you don't have an option. So we should not be very cost sensitive when we offer a good treatment for COPD. So he was flying Emirates to US, and then he was asking me, telling me that this is becoming a little expensive.
Yes.
So we should not be very cost sensitive. ये महंगा है इसको काम करने के लिए. Give the best treatment. That's what I believe. We should offer the best treatment because in order to reduce say $500 for him, we may compromise his clinical outcome.
Correct. So at first hand, we should give the best advice to the patient.
Right, sir.
Correct.
Lots of with Indecatrol glycopyrronium, this was the problem we were facing.
Yes.
Expensive. Everywhere expensive. No one was talking about the molecule.
Yes.
Always were like expensive.
Yes.
So doctors should not be very cost sensitive.
Yes. But the pharmaceutical companies are now telling that the price has come down, reduced. They have reduced
now
the price.
900 rupees. 950.
Yes. So it can be affordable to most of the patients.
Now it is a wonderful thing for.
Okay. So now we have come to the end of this panel discussion today, and I want to just give this take-home message of today's discussion that long-acting bronchodilators are the central to the COPD management. And precision medicine for bronchodilator is that we have to select the molecule, we have to select the dosing schedule once daily or twice daily, and also the inhaler type according to the type of the patients. There is definite beneficial role of the dual bronchodilator, and it has become the cornerstone for the COPD treatment. I think all the patients with symptomatic patient with COPD, with or without exacerbation, can be started with the dual bronchodilator. And in some cases, according to the need, it can be step up to the triple therapy. But dual bronchodilation is becoming the standard treatment for all group of the patients. And single inhaler triple therapy reduces symptom as well, exacerbation. And single inhaler triple therapy is an important advance for a selected group of the severe COPD patients. So precision medicine again we should use the blood eosinophil to predict the benefit effect of the ICS. Without doing blood eosinophil, we should not add ICS. So we should make a practice of monitoring our patients or adding ICS on the basis of blood eosinophil as well as the frequency of the exacerbations. And Gold 2020 shows a personalized way to use ICS. They have given a clear-cut chart for the strong evidence for the giving ICS, the consideration of ICS, and when ICS should not be given. So Gold guideline has given a clear-cut recommendation in these situations. So with this, we can end our topic. And I would like to thank again everybody, Dr. Apar, Dr. Prashant, Dr. Abhishek and Dr. Anil. And again, I would like to thank Dr. Sachin and Assess and other person on the technical parts here in the loop. So
Okay.
over to you, Dr. Sachin. Yes.
Okay. Thank you very much, sir. Yeah, thank you very
Stop
much.
sharing, sir. Let me stop sharing.
Yeah. So on behalf of Lupin, so let me conclude by saying a big thank you to Dr. Shamal sir to making the today's webinar so interactive. So it is a very learning treat for all the participants. Dr. Apar Jindal sir for his excellent talk on precision medicine. Dr. Prashant sir, so the case-based approach and not the least, Dr. Abhishek Kumar sir and Dr. Anil Agrawal sir for making the discussions so interactive. Also to all the participants, those who joined later, so recorded version of the present webinar will be available on Lupin India Facebook page. So it will be great, sir, if you say a goodbye, your
Yes, sir.
concluding remark from your end. Dr. Shamal sir.
But
Any
one
concluding-
thing I forget about is there any question from the audience?
Sir,
Just
yes,
we should respond here.
there are the questions, but the good thing is that during our interactions, that panel discussion, most of the questions were being answered. So as there is only one question, so it is somehow of related to the topic. So the doctor from Kolkata wants to know the benefits of pranayam. The rest of the questions with respect to indacaterol, glycopyrronium, cyclosinamide, ICS, azithro, we all discussed. So you can give a concluding remark, the benefit of pranayam in COPD.
A special comment will be given by Dr. Prashant. He's from West
Okay.
Bengal. Dr.
Okay,
Prashant.
okay, that's great, sir. Yes, Prashant,
Dr.
sir.
Prashant, give your
Yes, sir.
opinion.
So pranayam, if I don't know pranayam very well, but then if I understand it correctly, this is nothing but deep breathing. So deep breathing in COPD, I think is helpful. That's what I understand. So pranayam definitely in airway disease, this should help. But honestly speaking, I'm not very technically well versed with pranayam.
Definitely, it will increase the diaphragm and the intercostal muscle strength. Definitely. So rest in improvement. Secondly, it will open up the small airways. So it will to some extent correct the ventilation perfusion mismatch to some extent. With deep breathing, the small unrecruited alveoli or small airways which kept closed, that can be opened with the deep breathing systems. So more recruitment and more better ventilation of the small airways and the alveoli. Definitely pranayam helps, and definitely improving or boost up of the exercise, respiratory muscles, intercostal muscles, and diaphragmatic strength definitely increased. So pranayam, along with the pharmacological treatment and along with the other non-pharmacological treatment like vaccines, rehabilitations, and other things. So that is in fact, a combined mode of treatment, a team approach that can improve the patient's daily life or quality of life in COPD patients. Dr. Apar, would you add about the pranayam?
I think so. You've very well covered most of it. So pranayam also becomes part of the breathing exercises only, which is very well part of the pulmonary rehabilitation, an important part of therapy that needs to be offered to every COPD patient. So you've covered it very well. I don't think there's anything more to add over there.
Okay, thank you. Thank you. Dr. Sachin, any question?
Yeah. So most of the questions I already discussed. So there is one recent addition that indacaterol glycopyrronium can be given specifically to the patients with poor lung function and severe dyspnea, considering the DPI formulations. We already discussed. Any concluding remark from your end, sir?
So, in my opinion, this dual bronchodilator combination with glyco and indacaterol is the best combination. And we should use it in all the patients. Well, it is available in the OD formulation, but in the US it is also available in the BD formulation. Same combination of the drug, it is available in the BD formulation in US. So it may be that after some time we can have a BD formulation or BD packing as well. So at the present moment, we should use the OD drug. And if the patient needs after having the poor control and having nocturnal symptoms, we can think about the PT preparations here. But definitely all the patients of COPD should start treatment with dual bronchodilation and this glycoindicator combinations. In my opinion.
Okay.
Thank you.
Yes, sir. Thank you very much. And a big thank you to all the guests, all the faculties, all the panelists, and all the participants. Thank you very much. Good night,
Thank
and we can go offline now.
Yes. Thank you, Dr. Apar Prashant.
Thank you, everyone. Thank you, sir.
Thank you, sir. Thank you so much, sir.
Thanks a lot, sir. Thanks a lot. Dr. Sachin,
Yes.
again, your smiling face. Thank you so much for wonderful moderating and wonderful intercession. And Dr. Prashant Kumar and Dr. Jindal, sir, is an absolutely brilliant session. Absolutely brilliant session. Now we are going to sharing also the counts, how many participants are also attending this program. Our main objective of the program to reach to all the physicians and the cardiologists, and I believe how the things are designing and how the Dr. Samuel are also asking the question is really related to the physician practice and the cardiology practice. I believe this particular program is really going to help all the physicians who have attended this session. Thank you so much on behalf of Blueprint Respira. From my core of my heart is convey my regards and gratitude to you all. Thank you so much. Thank you.
Thank you.
Bye, Prashant.
Bye. Good night.
Dr. Agarwal also, sir. I think Dr. Agarwal again joined. Dr. Agarwal, thank you again to you.